You know, usually when we talk about abdominal pain on one of these deep dives, we're almost always looking at the acute stuff.
Right. The sudden catastrophes.
Exactly. A burst appendix, a perforated ulcer, the things that really scream at you and demand immediate attention.
Yeah, the things that land you in the emergency room at 3 in the morning. No question about the diagnosis.
But I've been looking through this stack of clinical pearls on pancreatitis, and there's this one specific patient profile that, honestly, it really unsettled me.
I think I know the one you're talking about. It's much quieter.
It's quieter, darker, and just a lot more complex.
Are you talking about the silent jaundice scenario?
That's the one. It's basically the cold open in the case files we have here.
Okay.
So picture this. A middle-aged guy.
Okay.
He's been dealing with this nagging gut pain for years. Maybe he drinks a bit too much. Maybe he's had these little flare-ups before that he just sort of ignored.
A very common story, unfortunately.
So you take an x-ray, and his pancreas just looks like it's full of gravel. I mean,
Yeah.
calcifications everywhere.
Which is the classic, absolutely textbook picture of chronic pancreatitis.
Right.
At that moment, I think most clinicians are thinking, okay, we know what this is. Manage the pain, get him to stop drinking, get him on some enzyme supplements.
It feels like a case closed situation, doesn't it?
It really does. You feel like you've got it figured out.
But then the plot twists. He comes back a few months later. He's lost, say, 20 pounds, and it was rapid.
Mm-hmm. A big red flag.
And his eyes are turning yellow.
Jaundice.
And the terrifying part of this whole literature, the thing I couldn't shake, is the question it forces you to ask.
Is this just the natural progression of his chronic disease getting worse?
Or is it something else entirely? Something new and much, much worse?
And that distinction, that is the million-dollar question for medical boards, but I mean, for the patient, it's a life or death distinction.
Because you're trying to distinguish between a scarred, sort of burnt-out organ.
And carcinoma, cancer of the head of the pancreas.
And that is exactly what we're digging into today. Not just the simple, what is pancreatitis, but that really high-stakes detective work.
Yeah, the nuance is everything here.
We need to understand why the organ turns to stone, why it can fool us on the blood tests, and most importantly, how to spot that narrow window where a surgeon can actually intervene.
It's a messy topic.
Yeah.
It really is. It sits right at the intersection of lifestyle choices, some really fascinating genetics, and some very complex anatomy.
But I get the sense that if you really understand the mechanism, the why behind it all.
Then the management becomes incredibly logical. It all just clicks into place.
So let's start there. Let's start with that mechanism. The source material uses this one word repeatedly when it defines chronic pancreatitis. Irreversible.
It's a heavy word.
That feels like a really heavy word in medicine.
It is, and it's the fundamental, absolute difference between acute and chronic pancreatitis.
Okay, so with acute, the house is on fire.
Right. In acute pancreatitis, the house is on fire. But if you put the fire out quickly, the structure can often be rebuilt. The organ can heal, it can return to normal function.
But chronic is different.
Chronic pancreatitis is a whole different ballgame.
So it's not a fire, it's more like a slow, deliberate demolition.
That's a really good way to put it.
Yes.
It is a progressive inflammatory disease where the normal functional tissue is slowly replaced by fibrosis.
Scar tissue.
Just scar tissue. And once that scar tissue forms, it doesn't turn back into a healthy gland. It is a one-way street. There's no going back.
And looking at the pathology reports here, it's not just the scarring, is it? It's like a total restructuring of the plumbing.
The architecture is destroyed.
Yeah, we see strictures, which are these like tight, narrowing spots in the ducts.
Like kinks in a hose.
And we see those calcifications I mentioned at the top, literally stones forming inside the organ itself.
Precisely. So imagine a garden hose that's been pinched in multiple places and then filled with gravel. That is basically the pancreatic duct in this disease.
Okay, that's a powerful visual.
And this structural damage, this plumbing nightmare, it leads directly to the two main failures we see in the organ.
The exocrine failure and the endocrine failure.
That's right. The two big jobs of the pancreas.
I really want to unpack the timeline of those failures because I have to admit I found it really counterintuitive at first.
I think a lot of people do.
So just to define our terms, exocrine is the digestion part. It's making the enzymes that break down our lunch.
Correct. Lipase for fats, amylase for carbs, and so on.
And endocrine is the hormonal part. We're mostly talking about insulin and regulating blood sugar.
Yes, the islets of Langerhans making insulin and glucagon.
Now, my gut assumption would have been that those delicate little islet cells, the ones making the insulin, they'd be the first to go. They seem more fragile.
It seems logical, doesn't it?
Yeah.
But the literature is very clear. It's the other way around.
The opposite.
The opposite. The axonar cells,
Yeah.
those are the workhorses, the factories pumping out all the digestive enzymes, they are typically destroyed before the islets of Langerhans.
So just to walk through the logic of that, a patient is going to have trouble digesting their food, really digesting fats, before they become diabetic.
In the typical progression, yes. Exocrine insufficiency, the digestive failure, almost always precedes endocrine insufficiency.
That's a huge clinical pearl.
It's a crucial logical step for staging the disease in your mind. If you see a patient who has already diabetic from their pancreatitis, you can assume their enzyme production has been shot for a very long time.
Wow. Okay. That really helps frame the severity. Now, before we get to what the patient actually feels, we have to talk about why this happens in the first place. The etiology checklist, as the notes call it.
The list of culprits.
And I feel like everyone listening, even if they're not in medicine, knows the big one.
Oh, absolutely. Alcohol.
Right. The usual suspect.
Worldwide, alcohol is the most common cause, and it's not even close.
And it's not just a random association, is it? There's a mechanism.
Yes, it's a very clear dose-dependent relationship. Heavy, long-term consumption actually changes the chemical composition of the pancreatic fluid.
How so?
It makes the fluid much more protein-rich, thicker, sludgier, and that makes it prone to plugging up all the tiny little dusts inside the gland.
And that plug is the beginning of the problem.
That's the first domino to fall. It starts that whole vicious cycle of inflammation, scarring, and more obstruction.
But the sources here warn us pretty strongly not to get tunnel vision on alcohol.
You can't. It's a huge mistake.
Because if a patient doesn't drink and you just sort of shrug your shoulders and say idiopathic, you might miss something that's actually treatable or something genetic.
Absolutely. You have to go to the checklist. First, you have to look at obstructive causes.
Like a gallstone.
It could be a stone that's physically blocking the main duct, or maybe a stricture from a past trauma, like a car accident, anything that blocks the flow.
Okay, so mechanical blockages, what's next?
Then you have metabolic causes. The big one to remember for exams is hypercalcemia.
High calcium in the blood.
Exactly. For reasons we don't fully understand, high levels of calcium in the blood can actually trigger pancreatitis.
And then we get into the genetics. This is where the notes got really, really granular. And I was surprised to see cystic fibrosis on the list.
Yes, specifically the CFTR mutation. We almost always think of cystic fibrosis as a lung disease, primarily.
Right.
But the original name for the disease was actually cystic fibrosis of the pancreas. That's where it was first described.
So what does the mutation do to the pancreas?
It causes all the secretions in the body to become incredibly thick and sticky. In the pancreas, that means the digestive juices become, well, they become like glue.
So instead of water, you've got glue trying to flow through those tiny ducts.
Exactly. And that glue blocks everything up, leading to that same cycle of inflammation and scarring that we see with alcohol. It's just a different way to get to the same endpoint.
There was another mutation mentioned in here, PRSS1. It sounds like a license plate, but it seems to be a huge red flag for hereditary pancreatitis.
It is. The PRSS1 mutations affect the trypsinogen gene.
Okay, can you break that down for us?
Sure. So trypsinogen is the inactive form of a very powerful digestive enzyme called trypsin. Normally, it only gets activated once it's safely inside the intestine.
To digest food.
Right.
Right.
But this mutation causes it to activate prematurely inside the pancreas itself.
Oh, no.
Yeah. So instead of digesting the steak you just ate, the pancreas starts digesting itself.
That is a horrifying concept, autodigestion.
It is. And identifying that mutation is absolutely key because these patients, the ones with hereditary pancreatitis, have a significantly higher risk of developing pancreatic cancer later in life.
A much higher risk. Wow. Okay. Now, speaking of distinct causes, I want to pivot for a second to a very specific profile that the notes highlight as a favorite for exams in India, specifically the NEAT-PG.
Ah, yes. Tropical pancreatitis.
This one seemed to break all the rules of the middle-aged alcoholic stereotype we started with.
It really does. Tropical pancreatitis is a fascinating and, frankly, a tragic entity. The patient profile is almost the complete opposite of what we've been discussing.
How so?
It occurs in young people, very young people, often children or adolescents.
And it's not related to alcohol at all.
No. It is strongly associated with malnutrition and certain dietary factors. There's some thought it could involve toxic roots like cassava, though the exact mechanism is still being debated.
But the clinical picture that it paints is very specific.
Extremely specific. The notes mention large intraductal calculi.
Calculi are stones, right?
Right, but these are huge stones, much, much larger than what you typically see in alcoholic pancreatitis. We're talking stones that can fill the entire duct.
And the other key feature.
Because the damage is so severe and it starts so young, these patients develop diabetes very, very early in the course of the disease.
So if you're a clinician and you see a young patient, maybe from a specific region, with a history of malnutrition, massive stones on their x-ray, and already has diabetes.
You mark tropical pancreatitis on the exam and you move on.
Yeah.
It's a very distinct clinical fingerprint. You can't miss it.
Okay. The last cause on our list that I want to flag before we move on is the one the notes call the chameleon.
Autoimmune pancreatitis.
Yeah. We're going to do a deeper dive on this later because of how closely it mimics cancer. But just to categorize it for now, this is an IgG4-related disease.
Correct. It's a systemic autoimmune disease where the body's own antibodies, specifically a type called IgG4, start to attack the pancreas.
And the reason we separate this one out from everything else
Is that it's medical, not surgical. It's treatable.
because you can use steroids.
Exactly. Unlike the permanent scarring from alcohol or genetics, autoimmune pancreatitis can often be reversed or at least controlled with steroids.
So missing this diagnosis is a huge deal.
It's a tragedy because you might send someone for a massive life-altering surgery that they didn't need at all.
Wow. Okay, so to recap the why, we have alcohol, we have obstructions, we have genetics like CFTR and PRSS1, we have tropical malnutrition, and we have autoimmunity.
A pretty diverse list.
Now let's talk about the what. What is the patient actually experiencing? The text lists a classic symptom triad.
The triad is pain, statorrhea, and diabetes.
Let's break those down because the nuance in each one is really fascinating. The pain, for instance, it's not just a generic tummy ache.
No, not at all. It's a very specific kind of pain. It's epigastric, so right in the upper middle abdomen, and it classically radiates straight through to the back.
Why the back?
Anatomy. The pancreas sits way in the back of the abdomen in a space called the retroperitoneum. It's plastered right up against the spine and a big bundle of nerves.
So the inflammation irritates those nerves in the back.
Exactly. And patients often describe the pain as boring or penetrating, like something is drilling through them.
And what's the actual mechanism of the pain? Is it just the inflammation itself?
It's largely about pressure. Remember those strictures and stones we talked about? The duct is blocked, but the pancreas doesn't know that. It keeps trying to secrete its digestive juices against that blockage. That raises the pressure inside the duct system, the intraductal pressure.
So it's like trying to inflate a balloon that's already inside a stone wall.
That's a perfect analogy. And that pressure stretches the nerves embedded in the organ, and that stretching is what causes that deep, agonizing pain.
Which explains another classic feature. The pain gets worse after eating.
Right. As soon as you eat, your body sends a signal to the pancreas to start working. It tries to pump out enzymes, the pressure goes up even more, and the pain spikes.
This leads to a really specific behavioral symptom I saw mentioned in the notes, sitophobia.
Yes, the fear of eating.
It's a sad, vicious cycle, isn't it? The patient is hungry, they need nutrition, but they know that eating equals agony.
So they just stop eating. Or they eat very, very little.
And that contributes significantly to the weight loss we see. It's not just that they aren't absorbing food properly.
That's so that they aren't even putting it in their mouth in the first place.
Exactly. Okay, but let's talk about the absorption piece, because that brings us to the second part of the triad. Steatorrhea.
The fatty stool.
Can you describe what that actually is?
Sure. Because the pancreas isn't making enough lipase, which is the enzyme that breaks down fat, the fat you eat just passes straight through your digestive system undigested.
So the stool becomes oily, bulky.
Yes, it's often described as greasy, foul-smelling, and it can be difficult to flush. It's a very distinctive sign of malabsorption.
Now, I circled a statistic here that I'm calling the steatorrhea trap.
I think I know which one you mean.
Because logically, if my pancreas is starting to fail, I'd expect to see digestion issues pretty early on in the process, right?
You'd think so. It makes perfect sense. If the factory is shutting down, the product should stop appearing on the shelves pretty quickly.
But the data says the pancreas has this absolutely insane reserve capacity.
It's incredible. It's a testament to how over-engineered the organ is. You do not see clinical steatorrhea, that visible, obvious fatty stool, until more than 90% of the exocrine function is lost.
90%. That's staggering. So you can be walking around with just 10 or 15% of your pancreas working, and your digestion still looks basically normal to the naked eye.
That's correct. You might have some bloating or discomfort, but that classic, undeniable sign of steatorrhea won't show up until the organ has been almost completely decimated.
That is such a dangerous trap for a clinician. I mean, if you're waiting for the steatorrhea to show up to diagnose chronic pancreatitis.
You are way, way too late to the party.
Yeah.
You have missed the window to intervene early. Steatorrhea is essentially a terminal event for the gland's function.
Wow. And that brings us to the third point in the triad, diabetes.
Which fits our timeline perfectly. The islet cells, the ones that make insulin, are the last to burn out.
So you get the pain first for a long time, then eventually the malabsorption and steatorrhea, and then finally the diabetes sets in.
Exactly. The full triad is actually a sign of very advanced end-stage disease.
Okay, so we have a patient, they're in pain, they're losing weight. How do we prove what's going on? Let's move to part 4, the detective work. And it looks like the blood tests are another huge trap.
They're the biggest trap of all, I think, because in acute pancreatitis, we rely almost entirely on amylase and lipase levels.
Right. They shoot up in the blood because the inflamed cells are bursting open and leaking enzymes.
High enzymes equals pancreatitis. That's the rule we all learned.
In acute, yes. But in chronic pancreatitis, the levels of amylase and lipase are often completely frustratingly normal.
And this confuses so many people.
So why is that? The organ is still inflamed, isn't it?
Because the organ is burned out. There simply isn't enough healthy, functioning tissue left to produce a massive enzyme spike when it gets irritated.
I love that analogy you used earlier. The factory is closed, so there's no smoke coming out of the chimney.
Exactly. There's nothing left to leak.
So the huge takeaway here is a normal blood test, a normal lipase, does not rule out chronic pancreatitis.
Absolutely not. It's a critical teaching point. If you send a patient home because their lipase was normal, but they have that classic boring back pain and weight loss, you might be missing the diagnosis completely.
So if the blood tests are unreliable, what do we use instead?
We have to test the organ's function more directly. The go-to test these days is fecal elastase.
Okay, what's that?
Elastase is another enzyme made by the pancreas that should be present in the stool. It's pretty stable as it passes through the gut. So we test a stool sample, and if the elastase level is low, it's a very good sign that the pancreas isn't producing enough enzymes.
So it's a direct measure of exocrine insufficiency.
Exactly. It's much more reliable than the blood tests.
And what if we want to be absolutely certain and quantify the fat malabsorption?
Then you have to pull out the gold standard, which is the 72-hour fecal fat test.
72 hours? That sounds rigorous.
It's unpleasant for everyone involved, the patient and the lab staff, to collect every single bowel movement for 3 days while on a controlled fat diet.
And what's the threshold?
If there's more than 7 grams of fat per day in the stool, that officially defines steatorrhea. But honestly, in modern clinical practice, we rely much more heavily on imaging.
Okay, let's talk about the pictures, because this is where it gets really interesting. A plain old X-ray seems surprisingly useful here.
It is. It's an old school test, but it can be incredibly helpful. You just take a plain X-ray of the abdomen.
And you're looking for those calcifications.
You're looking for those little white specks scattered across the upper abdomen in the shape of the pancreas. If you see them in the right clinical context, it's basically diagnostic. Game over.
And if the X-ray is normal but we're still suspicious, we move up to a CT scan or an MRCP.
Right. And this is where we get the gold phrase for the exams, the one everyone has to know.
I want to spend a minute on this because the visual it creates is so vivid. The chain of lakes appearance.
It's the classic description of what the main pancreatic duct looks like on an ERCP or an MRCP scan.
Can you describe what's actually happening there physically inside the duct to create that image on the scan?
Absolutely. So imagine the main pancreatic duct. In a healthy person, it's just a smooth, thin tube like a straw.
Okay.
But in chronic pancreatitis, you have that fibrosis we talked about, the scarring. And what do scars do? They contract, they pull tight.
So you got these pinch points.
Exactly. You get these pinch points or strictures where the duct is squeezed almost completely shut.
Okay, so you have a pinch in the straw.
But the gland behind that pinch point is still trying to produce juice and push it through. So what happens to the pressure behind that pinch?
It builds up.
It builds up, and the duct wall balloons out. It dilates.
So you get a sequence, a pinch point, then a ballooned out section, then another pinch point, then another ballooned out section.
Exactly. A series of strictures and dilatations. And when you fill that duct with contrast dye and look at it on a scan, it looks just like a series of small lakes connected by narrow streams.
Chain of lakes.
The chain of lakes.
But the real insight here for me is that the chain of lakes isn't just a cool picture, it's a pressure map of the organ.
That is a fantastic way to put it. Yes, those lakes are the high-pressure zones. That is where the patient's pain is coming from.
And that visual directly explains the logic of the surgery we'll talk about later.
It does. You can't just drain one lake.
Right.
You have to somehow connect the entire chain to relieve the pressure.
Okay. Before we get to the surgery, we promised a deeper look at the chameleon.
Right. Autoimmune pancreatitis.
Why does this particular condition look so much like cancer on a scan?
It's all about the shape and pattern of the inflammation. Pancreatic cancer usually presents as a focal mass, a hard, irregular lump, typically in the head of the pancreas.
So one bad spot.
Right, but autoimmune pancreatitis causes a diffuse swelling. The entire organ gets inflamed and swollen in a uniform way.
And the visual metaphor for this one is pretty distinctive. I saw it in the notes.
The sausage-shaped pancreas.
A sausage? Really?
Yes, instead of the normal kind of lumpy, lobulated texture of a healthy pancreas or the hard mass of a tumor, the whole thing becomes smooth, swollen, and featureless. It literally looks like a sausage on a CT or MRI scan.
And the key lab clue to pair with that sausage shape is the IgG4 level.
Elevated serum IgG4 levels. If you see a sausage-shaped pancreas and a high IgG4, you need to put down the scalpel and pick up the prescription pad.
For steroids, prednisone.
Yes, and you'll see a dramatic response. The swelling will just melt away with steroid treatment. It's quite amazing.
Now, let's get to the absolute heart of the mystery we started this whole thing with, the critical differential. Chronic pancreatitis versus carcinoma of the head of the pancreas.
This is the highest stakes comparison.
So we have our middle-aged man. He has the calcifications. We know he has chronic pancreatitis. But now he has jaundice.
This is the danger zone because chronic pancreatitis and carcinoma share so many symptoms. The weight loss, the anorexia, that vague abdominal discomfort. But there are key differences that you absolutely have to hunt for.
Okay, let's compare them side by side. Let's start with pain.
Chronic pancreatitis is usually painful, often very, very painful.
Right. That boring, deep pain.
Carcinoma of the head of the pancreas in its early stages classically presents with painless jaundice.
That's terrifying. Why painless?
It's because the tumor grows slowly and it compresses the bile duct from the outside. It's an external compression. It doesn't necessarily cause that acute inflammation or that high-pressure stretching of the organ's capsule, at least not initially.
So the patient just turns yellow, but they don't necessarily feel sick in terms of pain.
Exactly. And that lack of a pain alarm bell is what makes it so deadly because it allows it to be diagnosed late.
Okay. What about the physical exam? There's a sign named after, I assume, a French doctor.
Courvoisier's sign, yes. This is huge for exams. Absolutely classic.
What is it?
Courvoisier's law or sign states, if you have a palpable gallbladder, meaning you can actually feel it when you press on the abdomen, and it is non-tender, it doesn't hurt when you press on it, in a jaundiced patient,
Yes.
that is unlikely to be from gallstones. It is cancer until proven otherwise.
Okay. Why non-tender? What's the logic there?
Because the obstruction from a tumor is slow and gradual. The gallbladder has weeks or months to stretch out and accommodate the backed-up bile. It becomes like a big, floppy, overinflated balloon.
Whereas with a gallstone.
A gallstone causes a sudden, acute obstruction. The gallbladder is either acutely inflamed and painful, or if it's a chronic stone disease, the wall of the gallbladder is often scarred and shrunken, so you can't feel it at all.
So big, palpable, non-tender gallbladder equals cancer. Shrunken or painful gallbladder points more towards stones or maybe chronic pancreatitis.
As a general rule, yes. And also, think about the calcifications. Calcifications on an X-ray strongly favor chronic pancreatitis.
Because cancer just acts too fast.
Exactly. A tumor usually doesn't have the years it takes to lay down those calcium stones.
But here's the cruel twist, and I think it's the solution to our cold open mystery.
The link between the two.
Yes. Chronic pancreatitis is itself a major risk factor for developing pancreatic carcinoma.
It's one of the most tragic ironies in medicine. The disease itself predisposes you to the cancer.
So you can have the calcifications and then get the cancer superimposed on top of it.
Exactly. And that is almost certainly what happened to our patient from the beginning. He had the gravel, the calcifications, the chronic pancreatitis for years.
He was stable, or at least had a stable baseline.
Right. But then the pattern changed. The pain might have changed character, or maybe it even got a little better, but then he developed this new, profound weight loss and that deepening, painless jaundice.
So the ultimate lesson here is Never, ever assume a chronic patient is stable.
You can't get complacent. Any change in the baseline symptoms of a known chronic pancreatitis patient warrants a full and immediate workup for malignancy.
A CT scan.
A good CT scan. Tumor markers like the CA19-9,
Right.
and potentially a biopsy to get tissue. Yeah, to be aggressive.
Let's move on to other complications. Aside from the terrifying slide into cancer, what else can go wrong in this burnt-out organ?
Well, the list is pretty long. You can get pseudocysts, which are these large, walled-off fluid collections that are rich in digestive enzymes.
And they can get huge, right?
They can get huge and cause pain or get infected. You can also get pancreatitis, which is where the main duct actually ruptures and starts leaking pancreatic juice directly into the abdominal cavity.
Filling the belly with fluid.
Yes. But I want to focus on a specific vascular complication that comes up on exams all the time because the anatomy is just so elegant and logical.
Okay.
Splenic vein thrombosis.
All right, you have to walk us through the geography here. Where are these things in relation to each other?
Okay, so the splenic vein, its job is to drain all the blood from the spleen, and its path takes it directly behind the body and tail of the pancreas.
It's practically touching it.
They are intimate neighbors. So if the pancreas is chronically inflamed and scarred,
That inflammation is going to spread to the vein wall.
exactly, it
Oh.
irritates the vein. That chronic inflammation can cause the blood flowing through that segment of the vein to clot. You get a thrombosis.
So now the main drain pipe from the spleen is plugged shut.
It's plugged. But the spleen is an organ. It's still pumping blood out. That blood has to go somewhere.
So it has to find a detour.
It has to find back roads. And the main back road system is a network of small veins called the short gastric veins, which run into the wall of the stomach.
So the blood from the spleen backs up and reroutes through the stomach wall.
Yes. And that high pressure causes the veins in the stomach wall to swell up like varicose veins. They're called gastric varices.
And what's the specific exam connection here? Why is this so important?
Because if you see isolated gastric varices, and that's the key word, isolated meaning you see swollen veins in the stomach, but the esophagus looks totally normal.
Then you have to think.
You have to think of splenic vein thrombosis, most likely caused by pancreatitis. It's a classic association.
Because if it were something like liver failure or cirrhosis, you'd see varices everywhere.
Everywhere. Esophagus, stomach, rectum. Liver failure backs up the entire portal system. But splenic vein thrombosis is a localized problem. It only backs up the left side of the system. It's a beautiful, pure plumbing problem.
That's fascinating. Okay, let's wrap this up with management. How do we actually fix this problem, or at least manage it? Step one is always medical.
And step one of medical management is stopping the ongoing damage. Alcohol cessation is completely non-negotiable. If the patient keeps drinking, no surgery or pill in the world is going to help them.
Okay, so stop the insult. What about managing the failure of the gland?
We simply have to replace what's missing. For the exocrine failure, we give them pancreatic enzyme supplements.
Pills they take with meals.
Exactly. They have to take them with every meal to help digest their food. For the endocrine failure, if they become diabetic, they'll need insulin.
And you mentioned something else. Don't forget the vitamins.
Yes, you can't forget the fat-soluble vitamins.
A, D, E, and K.
That's right. Since these patients aren't absorbing fat properly, they become deficient in these vitamins very, very rapidly. You have to supplement them.
But what if the pain is just intractable? What if the medical management fails and that chain of lakes is just causing too much pressure and misery?
Then you have to call the surgeons. And the names of these procedures are, they're legendary in surgery.
They are. And the key here is that you choose the right surgery based on the anatomy of the pancreatic duct.
Exactly. It's not one size fits all.
Let's start with the classic drainage procedure, the Puesto procedure.
The puesto, or more formally, a lateral pancreaticohagionostomy.
Try saying that 3 times fast.
It's a mouthful. But basically, remember our chain of lakes?
Yes, the blocked duct system.
The puesto procedure surgically slices that entire chain open longitudinally from the tail all the way to the head.
So you're unzipping the entire blocked hole.
You're unzipping it. Then you bring up a loop of intestine, the jejunum, and you sew it over that long opening you've created. So the whole pancreas drains directly into the gut.
It's a massive decompression.
A total decompression of the system. But, and this is the most important part for any exam, you can only do a puesto procedure if the pancreatic duct is significantly dilated.
You need a big enough target to sew the intestine to.
Right. If the duct is narrow, say less than 5 or 6 millimeters, you physically can't do the operation, it will fail.
So what if the duct isn't that dilated, but the real problem is a big inflammatory mass of scar tissue right in the head of the pancreas, blocking everything.
Then you might consider a Fray procedure.
Okay, what's a fray?
The Fray is a clever hybrid operation. The surgeon cores out the diseased, inflammatory head of the pancreas,
Yeah.
literally carving out the blockage,
Mm.
but they also make that long incision to drain the rest of the duct.
So it's a combination of resecting the head and draining the body and tail.
Exactly. It addresses both problems. And the advantage is that it keeps the duodenum and the bile duct intact, unlike the really big one.
The Whipple, the nuclear option.
The pancreaticoduodenectomy. Yes.
Yeah.
This is a massive resection, one of the biggest operations in general surgery.
What actually comes out in a Whipple?
You take the head of the pancreas, the entire gallbladder,
Mm-hmm.
the duodenum, which is the first part of the small intestine, part of the bile duct, and sometimes even a part of the stomach.
And in the context of just chronic pancreatitis, when would you ever pull that trigger?
It's pretty rare, but you do it if you have an inflammatory mass in the head of the pancreas, and you absolutely cannot rule out that it's a cancer.
So if you're suspicious of malignancy, you have to do the cancer operation.
You have to do the Whipple to be safe. Or sometimes if the pain is exclusively located in the head and nothing else has worked,
Yeah.
but you really try to avoid it if you can, because it changes the patient's physiology forever.
So to summarize the surgery, Poisteau to drain the lakes if the duct is wide,
Correct.
Fray to core out the head and drain the rest.
Yes, if the head is the main problem.
And Whipple if you really think it might be cancer.
That's the surgeon's basic decision tree.
Wow. We have covered a massive amount of ground today. I mean, from the irreversible fibrosis all the way to the chain of lakes, the alcohol versus the tropical mystery, and that terrifying slide into carcinoma.
It is a dense, dense topic. But I think if you hold on to that central thread of obstruction leads to pressure, the whole disease just makes logical sense.
I think so too. Let's do a quick rapid fire review just to lock in some of these key takeaways. The pearls. I'll throw the concept out, you give me the key association.
Sounds good. I'm ready.
Okay. Most common cause of chronic pancreatitis worldwide.
Alcohol, no question.
Tropical pancreatitis profile.
Young patient, malnutrition, very large interductal stones, and early onset diabetes.
Timeline of organ failure.
Exocrine, the digestion fails before endocrine, the insulin production.
Classic.
Creating strictures and dilatations of the duct.
Autoimmune pancreatitis appearance and treatment.
The sausage-shaped pancreas. Look for a high IgG4, and you treat it with steroids.
Isolated gastric varices on an endoscopy.
You have to think splenic vein thrombosis, and the cause is probably pancreatitis.
And finally, the go-to surgery for a painful, dilated pancreatic duct.
The Poisteau procedure, a longitudinal pancreaticojationostomy.
Perfect. And to finally close the loop on our case, our middle-aged man with a long history of the calcifications, but now with new weight loss and jaundice.
The diagnosis is almost certainly carcinoma of the pancreas, superimposed on his underlying chronic pancreatitis. That change in his baseline symptoms was the critical red flag.
And his next steps are urgent.
Incredibly urgent. He needs a high-quality CT scan, tumor markers drawn, and an oncology referral immediately. Any delay is critical.
It's a heavy ending, but it's such a powerful reminder that in medicine, the story isn't over just because you have a chronic diagnosis. You always have to be watching for the plot twist.
Constant vigilance, that's the job.
Well, that brings us to the end of this deep dive. Hopefully, the next time you hear the words epigastric pain radiating to the back, you'll see that whole chain of lakes in your mind.
And maybe next time we'll have to go even deeper into that dark territory we touched on today. The Whipple procedure. And the whole battle against pancreatic cancer itself.
That sounds like a tough one, but a necessary one. Until then, keep digging deep. Thanks for listening.